Hello everyone, how are you? I'm Dr. Shariful Halim and today I'm going to talk about lung volume and capacities in healthy and diseased people. So there are actually four volumes which are very important to know, especially the definitions. So there are tidal volume, the inspiratory reserve volume, expiratory reserve volume, and the residual volume. So the tidal volume is the most common volume which we actually use during our quiet inspiration or quiet expiration. So this is the air that moves into the lung with each quiet inspiration, which is about 500 ml or 0.5 liters. Very easy. And next is inspiratory reserve volume. So this is something we use during exercise. Suppose we need to take a deep breath. So first we take the tidal volume and next we take the inspiratory reserve volume. So this is the volume which can be inspired over and above the tidal volume. Then comes expiratory reserve volume. So this is the volume that can be expired after expiration of a tidal volume. Suppose we are taking a normal respiration. After a normal expiration, we are expiring more air from our lungs. So the more amount, the extra amount that we can expire from our lungs if we want forcibly, this is called expiratory reserve volume. Then comes the residual volume. So this is the volume that remains in the lungs after a maximal expiration. So this volume cannot be by any way expired from lungs. It must remain in your lungs. You can no way expire it out. And that's why you cannot measure it by spirometry. But all other volumes can be actually measured by spirometry. Next comes the capacities. So a capacity is a sum of two or more than two physiologic volumes. And there are four common capacities: inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. Among them, most important are vital capacity and functional residual capacity. So the inspiratory capacity is the combination or is the summation of tidal volume and the inspiratory reserve volume. Functional residual capacity is a summation of residual volume with expiratory reserve volume. So this is actually the most common volume that resides in our lung after a normal expiration. So this is the volume that suppose we are expiring normally, and then if we measure the total volume in the lungs, though we cannot do that, if we measure in a hypothetical situation, the volume in the lung will be the functional residual capacity. And as it has residual volume in its equation, it cannot be measured by spirometry. Next comes the vital capacity, which I think the most important capacity that you have to learn. And the volumes that are included in vital capacity are tidal volume, inspiratory reserve volume, and expiratory reserve volume. So vital capacity is actually measured by spirometry commonly, and this is the volume of air that can be forcibly expired after a maximal inspiration. So suppose you take a normal breath, which is the tidal volume, then you do not stop there and take more, so it will be the inspiratory reserve volume. And after expiring a normal breath, after maximal inspiration, you expire maximally. So when you expire maximally, you will expire the inspiratory reserve volume, then you will expire the tidal volume, and ultimately you will expire the expiratory reserve volume. So again, this is the volume of air that can be forcibly expired after a maximal inspiration. Very important to know. Last one is total lung capacity. So it is actually the summation of all the volumes: inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. So this is the volume in lungs that resides after a maximal inspiration. As it has residual volume in its calculation, it cannot be measured by spirometry. So here is a graph to show you the typical volumes and capacities. So in the left side you have the volumes, and the right side you have the capacities. Let's first talk about the volumes. So first is tidal volume, which is very commonly used by us. So this is the lower volume, volume in the lung after expiration, which is about like 2.2 liters, and then we inspire. So after inspiration, the volume in the lungs becomes 2.7. So the tidal volume is 2.7 minus 2.2, which is about 0.5 liters. And then we expire again the tidal volume, inspire again the tidal volume, expire again, inspire again, expire. And then after a normal inspiration, if we take a deep inspiration, the extra volume that we can inhale is called the inspiratory reserve volume. And after taking a deep breath or inspiratory reserve volume, if we exhale normally from this point to this point, if we exhale normally, or if we measure the total volume that we can maximally inhale, adding up the tidal volume or tidal volume plus the inspiratory reserve volume, it will be the inspiratory capacity. So the maximum volume of air that can be inspired in a normal inspiration, in a forced inspiration, which is tidal volume plus inspiratory reserve volume, which is called the inspiratory capacity. And if someone who has already took a very deep breath, maximal deep breath, and now he's expiring as much as he can, the extra volume of air that he can expire other than tidal volume is called the expiratory reserve volume. So expiratory reserve volume is the volume that you can expire after expiring the tidal volume. So this is the maximal expiration. And the vital capacity is the total volume of air that you can expire after a maximum inspiration. So from here you inspire maximally and you go up to the maximum of inspiratory capacity, and you start exhaling. So if you start exhaling, so if first you have exhaled the inspiratory reserve volume, then you have exhaled the tidal volume, and ultimately you have exhaled the expiratory reserve volume. So all those volume, if we exhale all those volumes, the capacity it determines or denotes is called vital capacity, which is very important. And after exhaling a vital capacity, the volume of air that truly remains inside your lungs is called the residual volume. And after exhaling normally, suppose after exhaling only a tidal volume, the volume of air that remains in your lung after a normal exhalation or normal expiration is called the functional residual capacity. And if you add up all the volumes, it will be called a total lung capacity. I hope I made this clear. So a very important topic in spirometry is FEV1. So FEV1 is the volume of air that can be expired in the first second of a forced maximal expiration. And normally FEV1 is about 80% of the forced vital capacity, or simply the vital capacity. So the FEV1 FVC ratio is about 0.8. And in case of obstructive lung disease, where you have an obstruction of airflow during expiration, the FEV1 decreases, and the decrease or reduction in FEV1 is more than vital capacity, and that's why FEV1 FVC ratio is decreased. But in case of restrictive lung diseases such as fibrosis, there is a decrease in both FEV1 and forced vital capacity, but the reduction in forced vital capacity is more, and that's why FEV1 FVC ratio is either normal or sometimes it is increased. So here you can see some contrast between FEV1 in normal person, asthma people, and patients with fibrosis. So this is the normal FEV1 and FVC. So here in the y-axis you have the volume, in the x-axis you have the time. Suppose someone is breathing maximally after a maximal inspiration, so he's exhaling maximally after maximal inspiration, and the fast amount of volume that he expires in the first second is called the FEV1, and in the next 2 seconds or next 1 to 2 seconds, the extra volume and the total volume he can expire is called the forced vital capacity. So the forced vital capacity and FEV1 ratio is like 80%. So FEV1 by FVC is about 80% in normal people, so it's like 0.8. And in case of patients with asthma, there is reduction of FEV1 and FVC, but the reduction in FEV1 is more than the reduction in FVC, and that's why the ratio becomes less than 0.8. In case of fibrosis, there is also a reduction in forced vital capacity and FEV1, but the reduction in FEV1 is not not that much in relation to reduction in FVC, and that's why the ratio between FEV1 and FVC can be 0.8, or in some cases can be more than 0.8. So this is a basic difference, and here I put them in a chart, and that I brought this chart from BRS, and here you can see in the upper two panels the obstructive lung disease, which are asthma and COPD, which have the same kind of features. And in case of asthma and COPD, the main problem is with expiration. The patient cannot expire the air properly, and that's why there is a severe reduction in FEV1 and mild reduction in FVC, and the FEV1 and FVC ratio becomes lower than 0.8. And as the patient cannot expire the air fully, their air is trapped inside their lungs, and it increases the functional residual capacity inside their lungs. And in case of fibrosis, the main problem is with inspiration, and that's why the patient cannot inspire properly, and the forced vital capacity decrease severely. But the forced expiratory volume is not decreased that much, because when you expire, the fibrous bands put a radial traction on your airways, and that's why the airways are more open during expiration, which actually causes a mild decrease in FEV1, and that's why the FEV1 and FVC ratio can be normal, or in some cases can be increased, and the functional residual capacity is decreased, because as the lungs are fibrosed, the compliance of the lungs are decreased, and that's why the patient cannot inspire a lot of air. So the inspiratory reserve volume is decreased, and the patient's lung cannot expand properly, and that's why the residual volume is also decreased. So ultimately it leads to decreased functional residual capacity. So here there is another important concept, which is flow volume curves or loops. So these flow volume curves are depicting changes in flow in different lung volumes simply. So the flow is curved in the y-axis, and the lung volume is seen in the x-axis. And you have two phases in respiration, one is expiration and one is inspiration. And suppose we start, and there are multiple conditions depicted here. So you have one graph for normal person, one graph for obstructive lung disease, and one curve for restrictive defect. So let's first start with the normal person. So for a normal person, let's start the graph or start the plot at the functional residual capacity. So this is the functional residual capacity, or this is the residual volume. And now we ask the patient to inspire. So the patient is inspiring, and the flow during inspiration increases, and at the middle of inspiration the flow is highest, and then the flow actually begins to drop, and ultimately when the inspiration is complete, the flow is quite like zero. Now the volume becomes much higher after inspiration, and then we ask the patient to expire maximally. So the patient starts to expire, and when the patient starts to expire, the flow of air through the airway is increased, and it increased maximally. And after like the first 1/3 of expiration, the flow begins to drop, and then the volume again comes to the residual volume or the functional residual capacity. So this is the typical flow volume curve in a normal person. But whenever someone has an obstructive lung disease or restrictive defect, the flow volume curve changes. So let's look at them also. So in case of obstructive lung disease, the main defect is during expiration. And another important point in obstructive lung disease that I have already previously mentioned, that as in case of obstructive lung disease, the defect is in expiration, the patient cannot expire all the air that is inside their lungs, and that's why there is air trapping. So the residual volume increase and the functional residual capacity increase, and that's why you can see that the volumes actually starts from about 3 to 4 liters in case of obstructive lung disease. So in case of normal person, the functional residual capacity is not that high, but in case of obstructive lung disease, it becomes higher because the air is trapped as the expiration is impaired. So let's first start with this higher functional residual capacity, and then ask the patient to inspire. So the patient is inspiring, the flow of air through the airways is increasing. Ultimately, after reaching a maximum point, it starts to decrease. So there is some problems with inspiration, but not that much. But when the patient starts to expire, their volume, the flow of air through their airway is increasing gradually, and it stops at certain point. And as you can see, you can make a big contrast here. So this is the maximum volume or maximum flow of air during expiration in a normal person, and this is the maximum flow of air during expiration in a patient with obstructive lung disease. So there is a serious drop of expiratory flow in obstructive lung disease, and ultimately it goes, after maximal expiration, it goes to the residual capacity, which is also higher. So this is the obstructive lung disease. And now let's talk about the restrictive lung diseases. So in case of restrictive lung diseases, you start with a lower residual volume or a lower residual capacity. As you can see, in normal person, the residual capacity or residual volume is here, but in case of restrictive defect, it is decreased. And the reason behind that, in case of restrictive defect, there is fibrosis in the lungs, and the fibrosis in the lungs actually reduces the volume of air that can be inside lungs, which actually reduces the residual volume. And in case of restrictive defect, the main defect you have is a defect during inspiration. So let's ask a patient to take the inspiration. So suppose he is taking the inspiration, and in the middle of inspiration, the inspiratory rate is maximum. And as you can see, this is the normal inspiration, normal maximal inspiration, and this is the maximal inspiration in a patient with restrictive defect. And there is a sharp decline in inspiratory flow in patients with restrictive lung disease. And this is the main difference between obstructive and restrictive disease. In obstructive disease, the main defect is during expiration. There is a serious drop of expiratory flow. In case of restrictive disease, there is a serious drop in inspiratory flow. I think that should cover the maximum important points in flow volume curves. Let's move forward. Here we have a question. Which is, a 34-year-old man undergoes a pulmonary function testing for workup of dyspnea. His pulmonary curve is shown on the red line in the slide below, in comparison with a normal individual in the blue line. So here you can see the red line is the patient and the blue line is the normal person. So the question is, which of the following measures is increased in this patient? You can pause and you can answer yourself. I'm answering the question, and the answer to this question will be E, which is the residual volume by total lung capacity ratio. So this is the only increased ratio here. So why is so? As you can see here, in this blue line or red line, this is the tidal volume, this is the inspiratory reserve volume, and ultimately this is the vital capacity. So this is the vital capacity in a normal person, and this is the vital capacity in this person. So his or her vital capacity is reduced, and when the vital capacity is reduced, there is some increase in the residual volume and residual capacities. So there is increase in residual volume in relation to normal person, and as there is increase in residual volume, the residual volume to total lung capacity ratio should increase, because the total lung capacity remains almost the same, but the residual volume increases. That's why the answer should be increased residual volume by total lung capacity ratio. So let's solve another question. So here we have a 65-year-old male with a long history of COPD, and he's brought to the emergency room complaining of shortness of breath, fever, yellow sputum, and lower extremity edema. Physical examination reveals cyanosis, finger clubbing, and bilateral lung wheezes. Which of the following finding is most likely in this patient? So here the answer is E. So the answer is decreased cerebral vascular resistance. So why is so? First of all, the patient is an older patient who has a history of COPD, and then this patient have an exacerbation of COPD, which is manifested by shortness of breath, fever, yellow sputum. So the exacerbation is most likely due to an infection like pneumonia. and the patient also has lower extremity edema. So the lower extremity edema in a patient with COPD should tell you that this patient have a predominant chronic bronchitis. So this patient mainly has chronic bronchitis. And the physical examination also reveals cyanosis, finger clubbing, and bilateral lung wheezes. So bilateral lung wheezes tells you also about the chronic bronchitis. And next, in case of chronic bronchitis, what you have an obstruction in the airway. Whenever you have an obstruction in the airway, this will lead to accumulation of carbon dioxide in your blood, because you cannot expire the carbon dioxide as much as you can. So there is increased carbon dioxide level in your blood. And whenever you have an increased carbon dioxide level, it's called hypercapnia. And carbon dioxide is an important vasodilator in the cerebral circulation. So whenever carbon dioxide causes vasodilation in the cerebral circulation, it will cause decreased cerebral vascular resistance. I hope you have understood this question. Next question. A 54-year-old man comes to the physician because of progressive shortness of breath that has been occurring slowly over the last 6 months. Physical examination of the patient reveals bilateral crackles on pulmonary auscultation and drumstick-shaped fingers. The physician decides to evaluate him for diffuse interstitial lung disease. Pulmonary function testing reveals a decreased forced vital capacity, a supranormal FeV1-FVC ratio, and an increased expiratory flow rates. This patient's increased expiratory flow rates are best explained by an increase in which of the following? And the answer is here is D. Why so? So in case of restrictive lung disease like DPLD or diffuse interstitial lung disease, the problem is with inspiration. There is no problem with expiration, first of all. Next is, in case of expiration, the fibrosis that occurs in the lungs in interstitial lung disease actually helps the expiration, because suppose we have some airways here like that, and we have fibrosis outside the airway. So the fibrosis that is outside the airway actually tracks or pulls the airways outside. So there is some radial traction of the airways to the outside, and that's why there is increased volume inside the airways, which actually helps the expiration. So the answer is radial traction on airway walls by the fibrous bands or the fibrosis in DPLD, increasing the expiratory rates. We have another related case here, which is a 32-year-old female with claustrophobia, fear of closed spaces, is stuck in a malfunctioning elevator. She experiences severe anxiety as well as dizziness, weakness, and blurred vision. Which of the following is the most likely cause of this patient's symptoms? So the answer here, take a moment. Answer here is C. Decreased arterial carbon dioxide tension. So why is so? So in case of claustrophobic patient, whenever they are inside in a closed space, they start to hyperventilate, and hyperventilation causes a decreased level of carbon dioxide in your blood. And whenever carbon dioxide level is severely reduced, it causes vasoconstriction in the cerebral vessels, because carbon dioxide is, as you know, carbon dioxide has a very important effect on cerebral vasculature. So whenever carbon dioxide is high, it causes cerebral vasodilation, and whenever carbon dioxide is low, it causes cerebral vasoconstriction. And cerebral vasoconstriction leads to a reduction in blood flow to the brain, which leads to dizziness, weakness, and blurred vision. I hope I answered your question. And one very interesting case here. So this case is a healthy 34-year-old man undergoes spirometry testing as a part of pre-employment evaluation. He asked to breathe normally during the first few breaths, and then is told to take a full inspiration and exhale maximally. His spirometry tracings are shown below. At which of the following lung volumes would total pulmonary vascular resistance be the lowest? So question is, at which of the following lung volumes would total pulmonary vascular resistance be the lowest? So we have to find out the volume with the lowest pulmonary vascular resistance, and the answer here is, I'm pausing for a moment, take your answer. So answer here is C. So why the answer is C? So for the explanation, I have a picture which I brought from USMLE World. So in case of lungs, the vascular resistance in lungs is actually exerted by two sets of vessel. So one set of vessel are actually extra-alveolar vessel, and another set of vessel are alveolar vessels. So both of them combined, they put the pulmonary vascular resistance. So suppose we start from the residual volume. So whenever a patient starts to inhale after maximum expiration, and then after normal expiration he starts to inhale, the alveolar vessels starts to be compressed by the alveoli. So the alveolar vessels, which are red here, the alveolar vessels are starting to compressed by the expanding alveoli. So the expanding alveoli putting compression and traction on those alveolar vessels, increasing the resistance of the alveolar vessels. So after maximal inspiration, the alveolar vessel have a very high tension, very high pressure, leading to an increased total pulmonary vascular resistance. And suppose at the functional residual capacity, we are asking someone to expire maximally as he or she can. So we are asking the person to expire the expiratory reserve volume. So whenever someone starts to expire the expiratory reserve volume, here his lungs is kind of collapsing, and this puts a pressure on the extra-alveolar vessels. So extra-alveolar vessels are starting to be compressed, and as they start to be compressed, the resistance inside those vessels increase gradually, and ultimately it increases to a very high point, and the total resistance is also increased. And that's why during maximal inspiration, the resistance in the pulmonary vasculature is increased, and during maximal inspiration, the resistance in the pulmonary vasculature is also increased. The resistance is lowest at the functional residual capacity. So I think this answers the question. So here, this is the tidal volume, this is the inspiratory reserve volume, this is the expiratory reserve volume, and this is also, this here is the functional residual capacity. So functional residual capacity, as according to this picture, in functional residual capacity, the resistance in the pulmonary vasculature is lowest. So the answer is C. So at which of the following lung volume would pulmonary vascular resistance would be the lowest? So this is the lung volume where the pulmonary vascular resistance is lowest. So thanks all for watching my video. I hope it helped you a lot, and keep me in your prayers, please.